The first coronavirus case in the U.S. was confirmed on January 21. At that point, CDC began developing a test kit to diagnose coronavirus cases. The FDA gave CDC emergency authorization to manufacture and issue this test kit around February 4th. Isn't that right? Unfortunately, however, testing did not get underway because of problems with the test kits. Specifically, CDC's Atlanta manufacturing facility had quality control problems. On February 24th, 1 month after coronavirus was found in America, officials discovered that CDC's Atlanta facility was contaminated. Whether it was because of the contamination or biologic problems, which you had alluded to, test kits coming from that facility were flawed and had to be replaced, dramatically slowing down our response. Dr. Redfield, I know you are investigating the cause of the contamination in the Atlanta facility. Is the person who oversaw the Atlanta facility at the time of the contamination still in charge of the current manufacturing process?
This is currently under an investigation at this point, and I think I'm going to leave it there.
Sir, you can't give us assurance that the person who bungled the production process, it hasn't been removed. Recovering from that misstep cost us precious weeks and now months, sir. Meanwhile, the virus spread and people died. I respectfully disagree with your earlier characterization that we had an aggressive response and we had an early diagnosis when 1 month after the first coronavirus case was detected, we still had not shipped still not shipped test kits to public labs. Now let's currently discuss testing efforts underway in the U.S. and other countries. You have a copy of this chart before you. We talked about South Korea and the U.S. Let me just drill down for a second because this is very instructive. The U.S. and South Korea both experienced their first confirmed coronavirus cases roughly within a day of each other. The U.S. on January 21st and South Korea on January 20th. Interestingly, both countries developed a test to diagnose coronavirus roughly around the same time. The U.S. on February 4th and South Korea on February 7th, just 3 days later. But then our testing at that point, the activities diverged dramatically. Here we have a chart that shows the testing activities of 4 countries, the U.S., South Korea, Italy, and the U.K., on 3 separate dates in the past 3 weeks. You see, from 0 till March 10th, South Korea tested 4,000 people for every million persons in its population. Italy, in the blue bar, tested 1,000 people for every million people in the population. UK, 400 for every million. Now, where is the red bar representing the United States, Dr. Redfield?
I don't see it on that graph.
I don't see it either, but I can assure you that the data is there. It just doesn't show up. It doesn't show up. It turns out that Korea had tested 4,000 people for every million of its citizenry, and we are at 15 people for every million people in this country. That's a response, a testing response that's almost 300 times more aggressive than what's here in this country. And the problem, Dr. Redfield, is that when we don't test as rapidly as we should, the virus spreads and people die. Now let's talk about the situation going forward. Vice President Mike Pence said on Monday, quote, "Before the end of this week, another 4 million tests will be distributed." But the real question I submit is not when the tests will be distributed, it's when the tests will be performed on people so that they can know whether they have contracted coronavirus. Now, South Korea currently tests 15,000 people per day. Whether it's through high throughput, low throughput, medium throughput, it doesn't matter. They test 15,000 people per day. Dr. Redfield, when are we going to be reaching 15,000 people per day tested in this country?
Well, first I'd say, Mr. Congressman, it really does depend on the clinical indication. I think one thing I would like to point out again, the CDC developed this test for the United States public health system. We did not develop this test for all of clinical medicine. the test for clinical medicine, we count on the private sector to work together with the FDA to bring those tests to bear. And I said, finally,
So you're blaming the private
I'm
sector.
not blaming, I'm just
You're
trying
passing the buck to
I
the
am
private
not
sector.
blaming.
Sir, because of this, the virus is spreading, people are getting sick, people are dying. Thank you.
The gentleman yields back. The gentleman from Kentucky, Mr. Comer, is recognized for 5 minutes.
Thank you, Madam Chairman, and I cannot think of a more important committee hearing that would take place in Congress this week than the one we're having now. And I was very glad to see Congress come together last week in a bipartisan way after we've spent many months in a very partisan environment here with respect to the impeachment hearing. But Congress came together to pass a very important corona supplemental that I think everyone would agree is making a huge difference in America's defense against the coronavirus outbreak. But I've been very disappointed to hear some of the comments by my colleagues on the other side of the aisle. Chairwoman Maloney mentioned the political spin. Mr. Connolly mentioned the politicization and fake news. I just wanted to mention a couple of things that have been written and said by the press and Democrat leadership. The New York Times, a little over 2 weeks ago, had a headline, quote, "Let's call it Trump virus. If you're feeling awful, you know who to blame." And then House Majority Whip Jim Clyburn said, when asked if he had confidence in the administration's response, he said, quote, "Absolutely not. They're just fooling around. It just reminds me so much of Katrina." So I take a bit of issue with the politicization of something that should be focused on bipartisanship and working together to save lives. Because we have a crisis, Americans are truly and rightfully concerned, and I think that Congress needs to work hand in hand with the administration. I don't believe the administration's gotten the credit it deserves, especially with respect to the president's early decision to cut off the border, which has undoubtedly given the CDC and health officials time to prepare for this outbreak. I'm not confident the last administration would have made that decision for fear of political incorrectness or whatever. So I think the president should get a lot of credit for making that decision. But I want to focus on some things that are important to people in Kentucky because there's a lot of concern, there's a lot of misinformation. So my simple question would be to anyone on the panel, which are the best websites for concerned Americans to get onto that have factual information and important tips on how average everyday Americans can prepare for this?
So there are two. One is the core one is cdc.gov,
Okay.
and within that is coronavirus.gov. But cdc.gov will ultimately get you very quickly to anywhere you want to go.
Okay. So my next question to anyone on the panel, in the era of fake news and social media, how can Americans ensure that the information that they're sharing on their social media is accurate information? Do you have any advice on that?
Yeah, I think for the most part, at least from my experience, social media can often be as detrimental as it is helpful.
Right.
And that's the reason why, sir, I think the first question that you asked would be the one to go to the source of the data, CDC, and I'm not CDC, but I'm saying CDC is a data-driven organization. And if you really want the facts and the data, I would just go to cdc.gov.
We'll make sure our office, I'm sure just about every office here will start sharing that information. I want to switch gears in my last minute, represent along with Congressman Green, Fort Campbell Military Base, Fort Campbell, Kentucky, in Kentucky and Tennessee. But can you tell us what is being done to ensure that there's not an outbreak, first of all, on our military bases to protect our troops? Secondly, what our military is doing to be able to be in a position to help fight this if this is a mass outbreak?
I'll
Okay.
take that one.
Yes.
Thank you for the question. So we have put out a series of forced health protection guidance that is aligned to the CDC recommendations, and we have tailored those that guidance for forced health protection for military commanders, and particularly for installation commanders. And installation commanders and military commanders have a lot of latitude between right and left limits within our guidance that they can command and protect their military population. Now, what we're also doing is working with the interagency efforts to develop vaccines and also to develop antiviral treatments. And we are working with the interagency to develop what we call expeditionary field diagnostic kits, because we want kits that we can push far forward, because we have missions all over the world. We need to get our medical capability distributed.
Well, thank you, and hopefully Congress can work with you all in a bipartisan way. We can come together and help do everything we can to protect American lives. With that, Madam Chair, I yield back.
Thank you. The gentleman from Maryland, Mr. Raskin, is recognized for 5 minutes.
Thank you. Dr. Fauci, we've got two enemies in this crisis. One is the virus, and one is misinformation about the virus. And I want to quickly clear up a few things that have been said over the course of this process. One was by the president in early February when he said, it looks like by April, you know, in theory, when it gets a little warmer, it miraculously goes away. Is there any scientific reason to believe that?
The basis for any surmising that might happen is based on what we see every year with influenza, which actually, as you get to March and April and May, it actually goes way down, and other non-novel coronavirus, but common cold coronaviruses often do that. So for someone to at least consider that might happen is reasonable, but, underline but, we do not know what this virus is going to do. We would hope that as we get to warmer weather, it would go down. But we can't proceed under that assumption. We've got to assume that it's going to get worse and worse and worse.
Okay. The president predicted that there could be a vaccine in a few months. I think you contradicted that today, and I think you contradicted that at that time. I just want you to be very clear. Is there any chance we will have a vaccine in a few months?
No, I made myself clear in my statement.
Okay. Dr. Redfield, the first case of community spread of coronavirus took place on February 26th. That is infection of someone who did not have a clear travel history to China or direct contact with someone who did. Why wasn't the decision made on February 26th to expand your testing criteria for anyone displaying corona-like symptoms at that point instead of waiting until March 4th to broaden the criteria?
Well, that's a good question, Congressman. I mean, we always left the discretion to do testing to the local public health group. If you look, we always had that discretion. We never refused testing from anybody, but we did give guidance, as you point out, originally to do testing for individuals that presented with certain clinical scenarios secondary to travel to China. Those two cases in California and several others obviously led us to reconsider those and make it very clear that we wanted up front to tell clinicians if they suspect it and the health department suspect it, they should send that sample to the health department or us to CDC.
Okay, we've been hearing stories about people who've had very compelling reasons to get tested but were not able to. I'll give you one example. A nurse in California was quarantined after treating a patient who had coronavirus and then showed symptoms of the disease herself. On March 5th, the day after you brought in the testing criteria, she put out a statement about her situation, and she said, I quote, "The public county officer called me and verified my symptoms and agreed with testing, but the national CDC would not initiate testing. They said they would not test me because if I were wearing the recommended protective equipment, then I wouldn't have had the coronavirus." Are you familiar with this case?
No, and I would think that this is a misunderstanding if it did occur.
Okay, so what is the standing criteria, the existing criteria for testing now? So we have no confusion about it.
Again, it's if a clinical physician, a physician, nurse practitioner, healthcare provider feels a test is indicated, then we
Based on what?
based on their clinical assessment.
And that's based on does it require that the person have to have had contact with someone who had been on a cruise or who'd been to China?
This is their clinical assessment. We're not going to judge the clinical assessment. We also say if it's the clinical assessment or if it's the assessment of the public health department, that those individuals. And again, these are decisions. What happens is in the time when testing was limited to health departments, the local health department makes that decision, and then but they have followed CDC guidance. Now, we've made it very clear, it's up to the individual health provider and the individual public health to make that decision.
Okay, could you make a public service announcement right now for people who are asking the question of whether or not they should be tested? I hear from constituents who are having flu-like symptoms. They want to know, what should they do? What should they do?
Well, as Dr. Fauci said, the first thing I would do is to tell them to contact their healthcare provider or their emergency room and tell them they're concerned they may have coronavirus infection, and then follow their instructions to where to get the test. All right, and then proceed with getting the appropriate clinical evaluation.
Okay, so they should call someone before they go anywhere.
Well, we'd like to do that because if you really think you're infected, we're trying to avoid someone to walk into a 200-person, 100-person emergency room first. It's just a call in advance, and then they'll arrange exactly how they're going to get the test, how they're going to see the patient. They're going to be prepared when that patient comes to the emergency room that they're going to be able to isolate them, get them tested, get them properly evaluated.
Okay, thank you for your work on behalf of the American people. I yield back, Madam Chair.
Thank you. The gentleman from Texas, Mr. Cloud, is recognized for 5 minutes.
Thank you, Chairwoman. Thank you all for being here today. Appreciate your work on this. Dr. Redfield, I appreciated you talking about the ever-changing dynamics of the situation, especially in the sense that scientists even every day are learning more and more and how to deal with this and how to address it. It's been difficult, of course, to get information out to the public, especially in a hyper-politicized environment. I'd like to spend some time trying to clear the record on that as we try to find the proper balance between creating a proactive positive response to real threats as opposed to instigating overreaction on the public and finding that healthy balance. Dr. Fauci, can you, by way of comparison, briefly explain how does COVID-19 compare to other previous health situations, SARS, H1N1, things like that?
Sure, sir. Thank you for the question. Well, SARS was also a coronavirus in 2002. It infected 8,000 people, and it killed about 775. It had a mortality of about 9 to 10%. So that's only 8,000 people. In about a year, in the 2.5 months that we've had this coronavirus, as you know, we now have multiples of that. So it clearly is not as lethal, and I'll get to the lethality in a moment, but it certainly spreads better. Probably for the practical understanding of the American people, the seasonal flu that we deal with every year has a mortality of 0.1%. The stated mortality overall of this, when you look at all the data, including China, is about 3%. It first started off as 2 and now 3. I think if you count all the cases of minimally symptomatic or asymptomatic infection, that probably brings the mortality rate down to somewhere around 1%, which means it is 10 times more lethal than the seasonal flu. I think that's something that people can get their arms around and understand.
But less lethal than N1H1 or SARS?
No, absolutely not. H1N1 is even, the 2009 pandemic of H1N1 was even less lethal than the regular seasonal flu. It was a pandemic.
I'm trying to help the American people know where to appropriately set their gauge.
I think you set the gauge is that this is a really serious problem that we have to take seriously. I mean, people always say, well, the flu, the flu does this, the flu does that. The flu has a mortality of 0.1%.
Sure.
This has a mortality of 10 times that.
Okay.
And that's the reason why I want to emphasize we have to stay ahead of the game in preventing this.
Can we speak to the supply chain for a second? Dr. Kadlec, we're telling people to wash their hands, sanitation, all that kind of stuff. A lot of this stuff comes from China. They're going to the stores, seeing these dry up. What are we doing from the, I guess, FDA standpoint to ensure supply chains that we have all these, everything we need?
Sure, sir. I know there's been a run on Purell, but I think soap
Right.
and water works just as well, just in terms of that case. But it does require people to frequently wash their hands and maintain good hygiene, cover the cough, cover a sneeze, don't touch your face, and again, ensure that you continue to wash your hands, keep.
And my understanding in the legislation we just passed last week, too, face masks for health professionals, of course not for every citizen walking around, but for health professionals, that we have a U.S. supplier that could provide them, but we, House leadership didn't put the legal framework in it necessary. Is there anything the FDA is doing to allow U.S.-based companies to participate better?
Sir, I think one thing the FDA issued was emergency use authorization about expanding the use of particular masks and N95 respirators that could be used. There are two types, one used by industry, one used by the healthcare industry, and basically making that available for increased use so that numbers will be increased. There is a high demand for masks, particularly in the healthcare setting. Depending on what model you use, you may need up to 3.5 billion. That's a high number. That's a model. All models are wrong, but some are useful, and the number could be low as 600 million. And so what we're doing now is we're trying to increase the amount of masks that are available, both N95 respirators and surgical masks, which could be used in low-risk settings by healthcare workers. And in that way, we're issued a request for proposal for 500
I got time for one more question, if I
Yes,
can
sir.
move on.
Sorry.
Regarding testing, Dr. Fauci, we've had people calling 911 showing no symptoms, asking for an ambulance to take them to a hospital to be tested. So who should be tested? At what point should they be tested? At what point are the tests actually helpful? What about false negatives? Those kind of questions. Who should be really concerned about this?
Okay, so very briefly, as Dr. Redfield has responded multiple times on this, there were really two buckets, if you want to call it. If you have someone who has a reason to believe that they're infected, either that they have symptoms or they have come into contact with someone who is either travel-related or who is, in fact, documented to have been infected or exposed. That's something where you go to a physician, you get a test, and you find out if an individual is infected. The other that was discussed a fair amount over the last several minutes is a surveillance type, where you're not looking to see if anybody's been exposed, but you want to find what the penetrance of this particular infection is. And that's a different thing than the physician-patient relationship. That's trying to get a feel for what's out there. And that's what the CDC is doing now in 6 sentinel cities, and they will expand that throughout the country so that we will be able to, hopefully very soon, to get an idea, forgetting the people who think they may be infected, who actually is infected.
Thank you.
Its time has expired. The gentleman from California is recognized for 5 minutes.
Thank you, Madam Chair. Like all of the members up here, we are getting constant communication from our constituents wanting more information. And I applaud all of you for being forthright with the American public. That's exactly what we need. In times like this, communication is so important. And if you're going to err on one side or the other, over-communication clearly is more important than under-communication. Dr. Kadlec, I had the fortunate opportunity to be with you earlier this week and see firsthand the work that you are doing to help address this issue as well as your peers. I want to talk about one of the slides you shared with me, and it was a bell curve that showed what would happen across the United States as far as the spread of this disease if mitigation efforts were not taken by the American public and in your agencies, versus mitigation efforts to basically flatten that bell curve. And I think the primary purpose of that is so that our healthcare facilities and physicians, as well as the supplies, are not, for lack of a better term, overrun by a steep bell curve. Am I correct in making that statement?
Yes, sir.
And I think another way to say it, too, it's not a question of if, it's a question of when the virus continues to spread across the United States, but we want to pace it out as long as possible. Is that a correct statement as well?
Yes, sir.
Thank you. One of the issues, too, in helping address this is the fact that we do not have enough test kits. We know that many individuals, as my fellow member to the right of me, Mr. Raskin, pointed out, there are individuals who have requested test kits and have not been able to access them. My understanding is as late as last Saturday, ground zero in King County, Washington, that the healthcare professionals from that facility still did not have access to test kits. Mr. Redfield, do you know if that is true or not?
We have provided test kits to the health department. The University of Washington has developed their own tests.
Were those test kits available last Friday?
Yes, sir.
Thank you. And without test kits, is it possible that those that have been susceptible to influenza might have been miscategorized as to what they actually had, that it's quite possible that they actually had COVID-19?
The standard practice is the first thing you do is test for influenza. So if they had influenza, they would be positive for
But only if they were tested. So if they weren't tested, we don't know what they had.
Correct.
Okay. And if somebody dies from influenza, are we doing post-mortem testing to see whether it was influenza or whether it was COVID-19?
There is a surveillance system of death from pneumonia that the CDC has. It's not in every city, every state, every hospital.
So we could have people in the United States dying for what appears to be influenza when, in fact, it could be the coronavirus or COVID-19.
Some cases have been actually diagnosed that way in the United States today.
Thank you. I want to turn a little bit to the CDC website because I appreciate the information that you're putting out, and it's so important to the American public. But I also want to make sure that they fully understand it. On the CDC website is published a guide called, quote, Framework for Mitigation, Actions for Protecting Communities from COVID-19. In that graph, it provides 3 levels of transmission, none. In other words, you're in a community where there is no reports of any cases whatsoever. The second area is minimal to moderate, and the third is substantial. Dr. Redfield, how many cases of coronavirus are considered to be, quote, minimal to moderate?
Right now, when we see basically transmission cases, particularly if they're non-linked, we're looking at cases in the 25 to 50 range to see that groups begin to move into the moderate range, sir.
Okay, thank you. That's helpful. I would suggest that the CDC put that on their website so that the average American can read it and understand exactly the precautions they should take. So then substantial, I would assume, then, is when you have 50 cases or more in your community, you can consider it substantial?
Yes, sir.
Okay, thank you. And I would go back to Dr. Fauci. You talked about this is serious. We are seeing activities across the nation, school closing, sporting events being discussed about having them held in other places, major events being canceled or rescheduled. This would suggest this is a really serious issue, and I share the thoughts of the member from Wisconsin that I think we're concerned that we're not getting the full understanding or modeling that has taken place that would suggest the true impact of this virus across the United States, as well as potential models for deaths. Can you elaborate a little bit? And I get that there's no perfect model, but can you be helpful in helping us understand what we're really looking at here?
Yeah, if you look at the curves of outbreaks historically that are similar to this, the curve looks like this, and then it goes up exponentially. And that's the reason why it depends on how you respond now. So if we wait till we have many, many more cases, we will be multiple weeks behind. You know, I used the analogy at the press conference yesterday, and I'll use it today. It's the old metaphor that the Wayne Gretzky approach. You know, you skate not to where the puck is, but to where the puck is going to be. If we don't do very serious mitigation now, that what's going to happen is that we're going to be weeks behind, and the horse is going to be out of the barn. And that's the reason why we've been saying, even in areas of the country where there are no or few cases, we've got to change our behavior. We have to essentially assume that we are going to get hit. And that's why we talk about making mitigation and containment in a much more vigorous way. People ask, why would you want to make any mitigation? We don't have any cases. That's when you do it, because we want this curve to be this. And it's not going to do that unless we act now.
Thank you, Doctor. Madam Chair, I yield back.
Thank you so much. The gentleman from Ohio, Mr. Gibbs, is recognized for 5 minutes.
Thank you, Madam Chair. And thank you all for the work you're doing. It's a huge challenge, and I know the stress you must be under. And can never thank you enough, because I think the Institute of Health Center, CDC, and all our other agencies are doing the best they can in this unprecedented circumstance. I also was glad to see Governor Newsom in California come out and say some good things about the administration's doing and that help, and I think the governor of Washington State did the same. I talk about, about politicization, which shouldn't happen. We should be together on this. But one thing that really astounded me was all the talking heads and some members of Congress criticizing Vice President Mike Pence being kind of take the lead on this and head this up because he's not a medical professional. I would think when I look at this that person at that office, that level of that office, that helps bring the agencies together, maybe help clean out some of the red tape and the bureaucracy. Would you concur that that's been helpful to have that level of our top level of our government involved at that level for your working relationship, especially your working between agencies?
Yes, sir.
Absolutely.
I just want to make that point because I hear that criticism, and I think that they're either being political or they don't know what the heck they're talking about. Probably a little of both. I also think it's amazing. I want to praise the work the CDC's done to develop a test in 1 week. Is that unprecedented to develop a test from viral?
I'm going to have my friend Dr. Fauci answer.
I mean, obviously, the technologies of today are being able to develop a test as quickly as that, the same way as we were able to use the sequence to get a vaccine started, at least in the trial.
And I fully understand the vaccine, because you've got all the testing to make it safe and the efficacy and all that. But we're relatively close for an antiviral.
You know, you say relatively close. We don't know if it works, so I don't want to promise anything. We're testing them. If they are effective, they will be distributed. But you don't want to do that unless you know they are effective.
I do want to talk a little bit about the timeline. It broke in China, and then South Korea, Japan, Italy, and the United States, and elsewhere. As you say, it's really mushroomed. Seems to me, when I think about this, the next 4 weeks for us are really critical, because can we kind of maybe think we're getting information out of China? I know sometimes it's not reliable, but also we're seeing it happen in South Korea and Japan, that maybe they've peaked a little bit. Maybe they're on the better side of that curve now.
I think you're right, Congressman. Clearly, China is got control of their outbreak. They had 20 cases in the last 24 hours. Where our real threat right now is Europe. That's where the cases are coming in for. So in a way, if you want to just be blunt, Europe is the new China.
Okay, but I praise you for, Dr. Fauci's talking about doing as much mitigation as we can. It's critical, but I think, would you concur that my assessment the rest of this month, the next 4 weeks, is really a real critical time for us?
It's critical, yes, and it's critical because we must be much more serious as a country about what we might expect. We cannot look at and say, well, there are only a couple of cases here, that's good, because a couple of cases today are going to be many, many cases tomorrow.
We would like all Americans to take a good look at that mitigation strategy, as Tony said. We have 0, but they need to be fully engaged in that mitigation strategy, as well as those with moderate and more severe. This is the time for everyone to get engaged. This is not just a response for the government and the public health system. It's a response for all of America.
I understand that. Another thing that's not really being reported, because it's not as, raises the ratings and everything when they talk about the number of cases and the number of fatalities. But also I see in the reports worldwide, we have better than a 50% recovery rate. Is that true, right?
Right now, we'd say it's probably about 85%, sir.
No, 85% of people are affected are
recovering, 80 to 85, about 15 to 20%.
okay, it's even better than I thought. I was looking at the Johns Hopkins has that real-time chart, and there's like 120,000 confirmed cases and about 60,000 or something like that.
Real time, when you look at the chart, it's about half.
Okay.
But at the end of the day, if you look at historically, for example, the experience we've had with China, about 80% of them have disease that makes people sick, but they ultimately recover without substantial medical intervention. It's the 15 to 20% that have the serious disease and high mortality.
And the bulk of them have been people with underlying health conditions and over 70, right?
The elderly, as well as people with underlying conditions like heart disease, lung disease.
I'm out of time. I just want to say I think we just need to do what we need to do, be vigilant, but we also need to be responsible and not lose our heads on this, because I think we're going to get over this in due time with all the good work you're doing. Thank you, and I yield back.
Thank you. The gentleman from California, Mr. Khanna, is recognized for 5 minutes.
Thank you, Madam Chair. First, let me thank you, Dr. Fauci. I have known you, worked with you, and I have complete confidence in your leadership, appreciate your service. And Dr. Redfield, I think it's important to realize that you've served our country in the Army, you've served this nation. We need to be focused not on personalizing this, but figuring out what we can do to solve the issue. Now, one of the things that I think this should teach us as a country, with all the anti-government rhetoric, why do we need government? Government is the problem. How about we consider how inadequately we have been funding government and public health? The CDC budget is $11 billion, 1.5% of our defense budget, $738 billion. Dr. Redfield, do you think our country would have been safer if, let's say, we had twice the CDC budget, if we had put it at 3% of our national defense budget in our capacity?
Thank you, Congressman. I think it's important to realize that for decades, we've underinvested in the public health infrastructure of this nation. As many of you know, CDC's funding that we get from Congress, about 70% of it goes out to local and state, territorial and tribal health departments. They're the backbone of our health system. And if anything, I think you can look, I would rather see during my legacy to help over-prepare our nation's public health system with what I call the core capabilities of data monitorization and predictive analysis, laboratory capacity at the local public health labs, making sure we have the human personnel in the public health communities, the rapid response fund that we're very appreciative that Congress gave us, and build a global health security platform for the 2030, 2050.
And Dr. Redfield, while you have the country's attention, how much would that cost? Because right now we're spending, I think most people realize this is a national security issue. And we're putting 1.5% into the CDC of the defense budget. The NIH budget is $41 billion, which is less than 5% of national security. I mean, why isn't there a bipartisan call to double these budgets, triple these budgets? I mean, what would you ask the American people and Congress to prepare?
I appreciate the opportunity, Congressman, and I'd have to get back to you with an exact estimate of all that for you.
Dr. Fauci, do you have a view?
Yeah, I mean, we've been well funded at the NIH, but I think that we need to continue to have a consistent well funding. What happens is that there's inconsistency at times, but luckily over the last 4 or 5 years, the Congress has been quite generous with us.
One question I do have is the WHO had tests, and some of the other countries use these tests. Why shouldn't we be using these tests?
I think it's important to understand about the key for approving tests in this country from other countries. They can go ahead and apply through the FDA and get registration and be dispersed. Obviously, one of the reasons we developed the test that we developed was to try to make it as available as rapidly to the American public for public health. So I would defer that question to the Commissioner at what the exact hoops are for the foreign companies to get their test approved.
Do you think we need to look at streamlining in these types of crises, approval for things like WHO testing, which is 60 other countries are using, or there were stories in the New York Times about how leading scientists had come up with tests in Seattle that weren't approved? I mean, there's got to be a better way of getting these tests out there.
I will say that when this was recognized, when I was practicing in the Army, I could develop a test and then use it in clinical medicine. Somehow between then and now, there was not regulatory discretion for us to do laboratory-developed tests. The commissioner did, though, I think it was on February 29th, issue regulatory discretion so the University of Washington or say Columbia could actually develop their own test and actually use it. And rather than have to file what we call an emergency use authorization, they could start using their test and file that 15 days later.
Let me ask one final question. I genuinely believe that we have the most brilliant scientists, entrepreneurs in the world in the United States. And the question is, if we want to come up with an antiviral treatment, vaccine treatment, what is it, and I want both Dr. Fauci and Dr. Redfield to answer, what is it more that you need from Congress? Because no one cares about us lecturing people. No one cares about what we have to do. What are the resources that you need so that the scientists and the technology and the entrepreneurs can solve this?
From the NIH standpoint, it's the consistency of funding, which thankfully you've been able to do. You know, back from 1998 to 2003, you doubled the NIH budget. Then we went through a very, very flat, long period of time, which actually was very difficult because it discouraged young investigators from getting involved. For the last few years, we've had a good, consistent increase. What you can do is to continue to give the kind of investment in biomedical research that is consistent and predictable.
And I would say, first and foremost, the most important thing that you already have done is the establishment of the Rapid Response Fund. You know, prior to that, we would have to go to our foundation and ask them to raise money for us to respond to an emergency. Mm-hmm. The more flexibility you can do in enabling CDC to have a Rapid Infectious Disease Response Fund, I think is really one of the most important tools we have right now. And you all have started to do that already, and we're very thankful.
Thank you for that important point. The gentleman's time has expired. And let me intervene here. I've been told that our witnesses need to leave now. I don't know what is going on at the White House. The White House is telling reporters that this meeting is not an emergency. They are saying it was scheduled yesterday. However, that's not what your staff just told us. Your staff said the White House did not tell them about this sudden meeting until this morning, right before our hearing. There seems to be a great deal of confusion and a lack of coordination at the White House. I hope this does not reflect on the broader response to this crisis.
Madam Chair.
We have asked your staff if you can come back and resume this hearing at 2 o'clock after your meeting at the White House. They have not responded to our request.
Madam Chair.
I am not going to adjourn this hearing. I am going to recess it. We haven't even gotten through half of our members.
Madam Chair.
Either side of the, excuse me, I am.
When you have a moment.
No, I am finishing my statement. We haven't even gotten through half of our members. We will continue to work with your staff to have you back to finish the hearing and answer the rest of the questions from our members. Finally, let me close with this. This committee sent you a request for information a week ago. We asked for basic information about the crisis and your plans for the response, but you have not provided us with anything. We understand that you are incredibly busy, but a lot of this information should be at your fingertips. We need this information because we keep getting sometimes misinformation from the White House, and we have an independent obligation to the American people. So I have one last question. Will you commit to producing the information we requested, at least regarding testing, Dr. Fauci?
Madam Chairperson, I'm not sure what information you're referring to that we did not provide. We're talking about the National Institute of Allergy and Infectious
we
Diseases.
sent a letter with all the subcommittee chairs and myself requesting information to every department, yours, the CDC, FDA.
I will check this immediately after to find out
Thank
what
you.
the issue is.
Thank you,
Madam-
thank you.
Madam
Thank
Chair,
you very
may-
much.
may I just interject here for 1 second? I've got a timely issue. I know you all need to go down to the White House.
Madam
but
Chair, I do as
wanna-
well. I have a very specific district-related question. There are people in danger
Madam
in my
Chair,
community.
I've got the floor here for a second.
Please, we will yield to the ranking member and then to the gentlelady from Florida for the last question.
I think the chair. I think
with
the
all
chair.
due respect, I believe I was next in line.
Okay.
If we're,
All right.
if we're not gonna follow committee procedure.
Point well taken.
Thank you
Regular
very much,
order,
ma'am.
regular order. We are going to recess
As a ranking member.
after I recognize the ranking member for his closing statement.
Well, and I appreciate the chairwoman. We all recognize the importance of what's going on here, and I think it's important to have level heads about what's happening and that we want to make sure that you guys can go do your work. But it is important that you come back. It is extremely important that you come back. We do have urgent questions. I believe that the gentlelady from Florida has extreme concerns of urgency to the people that she represents. I can tell you that I do, representing San Antonio. I sent a letter, Dr. Foch, to the Department of Defense 2.5 weeks ago, and I've not received a response because I am troubled about the lack of response from the Department of Defense in helping us deal with the fact that we have people who have tested positive who are being held at an Air Force base in San Antonio, and we don't have a plan on what to do with them. I want to answer these. I want answers to these questions, and I want to be able to have you all respond to those questions when we come back. And I hope that will be this afternoon. Regardless of whatever needs to be discussed at the other end of Pennsylvania Avenue, I think there are very serious concerns that some of us want to have addressed. And I think that right now we've got 380 evacuees heading to a base in San Antonio. Yet I've got an email right here from City Council, Mayor, and leadership in San Antonio saying they don't have adequate plans on what to do with those who have tested positive. So I expect you all to come back down here today in accordance with what the chair is asking for so that we can have those questions answered. Thank you.
Well, responding to the ranking member, will you all be back at 2 o'clock today?
Now, we're going to have to just check. The reason I'm saying that, Madam Chairperson, is that we have a task force meeting at, what time is it? We have a task force meeting at 3:30 in the White House. I will get myself down here at 2 if you would like me down here, but I would have to be at the task force meeting at 3:30 in the White House. I don't know how we're going to work that.
We'll continue discussion. We'll stand at recess so that you can get to this meeting.
Right.
We are in recess.
Thank you.
Thank you. Thank you all for your service, your testimony. Tremendously helpful. Thank you.